Please welcome Gus.
Thank you. Thank you for being here today. So first of all, I have no disclosures, which is important because today I'm going to be talking a lot about consumer devices. You'll see a lot about Apple and Cardia, other brands that are out there making these things. I have no personal interest in them, but it's hard to avoid talking about products in a case like this. So as a brief overview, first of all, I just wanted to review the current medical heart rhythm monitoring devices. I didn't get much information on these as a resident about Holters, event monitors, or MCOTs, so I thought it'd be good to review, and you'll need to know those terms as we go forward in the presentation today. Also, working towards talking about remote monitoring with consumer devices, we'll review the evidence for and the challenges of screening for atrial fibrillation. And then finally, discuss the emerging consumer-driven heart rhythm monitoring technologies. So heart rhythm monitoring, primarily there are two purposes. First is diagnosis of symptomatic arrhythmias, so palpitations, syncope, pre-syncope. And the second reason would be to screen for or characterize asymptomatic but potentially dangerous arrhythmias, such as atrial fibrillation, which we know can cause strokes but is often silent. And you may not be as interested in this, but as an EP, I'm really interested in maybe patients who have PVCs, how frequently they're having PVCs, because that will guide therapy. So starting off in about the 1960s, we have the Holter monitor, which was invented by Norman Holter, which can be seen here wearing the first model of the Holter monitor. Luckily, this is actually an older image, but they're much smaller today, and they're even smaller than this. There are a few examples that are just worn as patches. These run for 24 to 48 hours. There are even some patches that run for up to 14 days. Their basic utility is capturing frequent events. So if you're just going to put a Holter monitor on for 24 or 48 hours, if you've got a patient who has syncope once every 2 months, you're probably going to miss it. These are also good for quantifying arrhythmia burden. They will count the number of PVCs. They will tell you the range of heart rate. The cons, they're short duration. There's no urgent notification. The reports for these are generated at the end of the device service. So once you take the device off, send it in, then you get a report. And there's a lot of information on these Holter monitors. Again, the heart rate range, minimum heart rate to maximum heart rate. Laser pointer here. You can have the heart rate variability, number of PACs, supraventricular runs, number of PVCs in a 24-hour period, pauses, how much very slow heart rates you have. So the next thing to evolve was the event monitor. These are known as loop recorders because they had an active memory that was continuously being overwritten. And ECG strips are stored by patient-indicated symptom. So if a patient had a palpitation, they could press a little button. It would record 60 seconds before the symptom and maybe 30 seconds afterwards, and you get an ECG of that to see exactly what the patient was experiencing. They also have automated detection. They have algorithms to recognize pauses, slow heart rates, runs of atrial fibrillation, for which the patient may actually be asymptomatic. And they can transmit data wirelessly, which is important because if a patient has a significant event, such as a prolonged pause, you may want to know about that rather than wait for the Holter monitor to be sent in, the data to be processed, and to be sent to you. So another advantage is that they last a pretty long time, up to 30 days. So their utility is capturing distinct arrhythmia events, and they're relatively inexpensive. But they do not provide you quantitative data. They don't tell you heart rate or activity burden or heart rate variability. Their detection algorithms are often inferior to the next iteration, which we'll see will be the MCOTs. So this is what a report for an event monitor looks like. There's not much there. It just lists the events that you have and provides you plenty of strips of those events. In this case, this patient had sinus rhythm with the PVC, and here you have a strip with a PVC. So going beyond this, we have the MCOTs, which I think are probably the best wearable monitors. They still have a device you can wear, and these also have patches. But I put a smartphone here because they're a little bit fancier than the event monitors. And they often communicate with a smartphone. So these are known as mobile cardiac telemetry, or MCOT. They provide continuous real-time EKGs, which are sent to an EKG lab. You still have patient-triggered and automated recording of events, and the monitoring period is typically up to 30 days. Their utility is that they're a long duration, 30 days for a wearable monitor. And they also capture quantitative arrhythmia and heart rate data. The cons is that they're relatively expensive. Oftentimes you'll order one of these and the insurance company will say, no, let's just put an event monitor on. So here's the sort of data you get from a MCOT report. It'll tell you how many episodes of atrial fibrillation, episodes of SVT, pauses, heart block, episodes of VT, quantified PVCs and PACs. So probably the king of heart rhythm monitors are the implantable monitors. So these actually get injected under the skin, so they're quite small. These are the two primary brands here in the United States, St. Jude and Medtronic. Inserting these devices is actually fairly easy. It takes maybe a minute or so. There's no anesthesia. They literally get injected under the skin with a little bit of local anesthetic. They can monitor for up to 36 months. They have patient-triggered and automated detection, just like the wearable monitors do. So their utility primary is in longevity. They can also transmit urgent events. And the downside is that it's an invasive procedure to put them in. They're very expensive. And one of the main things that requires regular monitoring. These devices can lose their communication. You have to be on top of them. You've got to have a staff of people to actually ensure that they're working properly. So just a summary on this first part here. Selecting the appropriate type of monitor is very important. So you need to ask yourself, when you're ordering a monitor, what is the frequency of events? If events occur just once a day, or occur reliably once a day or several times a day, a Holter monitor will probably be accurate. But if you have a patient who's had a serious episode of syncope, maybe once a year for the past 3 years, you're not going to catch it with a Holter monitor. So the next question is continuous or quantitative data needed? Do you need to quantify the number of PVCs? Do you have a patient who you're concerned about their heart rate range because they have persistent atrial fibrillation, and you're wondering, is their heart rate adequately controlled? So a Holter monitor may be adequate for that. And lastly, do you have suspicion of a potentially dangerous condition that would warrant urgent notification? Syncope, syncope, VT, or in some cases, atrial fibrillation. You would want to put on an MCOT or perhaps a Holter. So moving forward, talking about atrial fibrillation now, because that is one of the main diagnoses that we screen for with these monitors. And this is a pretty concise definition from the European Society for Cardiology. So atrial fibrillation is an ECG documented arrhythmia that has absolutely irregular RR intervals, and there are no discernible distinct P waves. And just by convention, arbitrarily, it's defined as episodes lasting more than 30 seconds. So AF obviously has serious consequences and costs. You know this, so I'm not going to review the data behind this. The information's here at CDC. It causes about 15 to 20% of ischemic strokes, more than 750,000 hospitalizations annually due to atrial fibrillation. It contributes to about 130,000 deaths per year, and the annual cost of AF is estimated to be $6 billion per year. Significant disease. So the prevalence of AF, and this is old data. It's from the Atria study in 2001. It's an HMO database of 1.9 million patients. About 18,000 of them had atrial fibrillation. The estimated prevalence was 0.9% with 2.3 million affected. Again, this is in 2001. And these are patients with diagnosis of AF in this database. That's fairly low. Currently, the estimation is about 2.7 to 6.1 million people in the U.S. have atrial fibrillation. It's because in the interim, we've been a lot more aggressive about looking for atrial fibrillation, particularly in patients with stroke. A lot of data, which we'll look at in a bit, we know that there's a lot of undiagnosed asymptomatic AFib. So what they were estimating in 2001, prevalence of 6-7 million to occur in about 2030 is actually what we have right now. One thing Atria got right, though, even though they got the numbers wrong, is that the prevalence of AFib increases dramatically with age. Individuals less than 65, the prevalence is less than 1%. But once you get over 65, the prevalence is over 10%. So we also know that atrial fibrillation is very asymptomatic. So this is an early trial from 1998 evaluating the efficacy of DDD pacers, those are dual chamber pacemakers, versus ventricular-only pacing in patients with sinus node dysfunction. Now, if you know just a little bit about pacemakers, if a patient's sinus node is not functioning in the atrium, you want to pace the atrium rather than just pace the ventricle all the time. There was an atrial arrhythmia sub-study for this trial, and 50% of enrollees had supraventricular arrhythmias over 28 days of monitoring. Again, it's a very high number, 50% of people with a supraventricular arrhythmia. But then again, a lot of these patients had AV dysynchrony due to the fact that they were VVI pacing with sinus node dysfunction. The important thing here is that 58% of these patients who had supraventricular arrhythmias had no idea that they were having supraventricular arrhythmias. Here, 458 patients with documented AF had a continuous monitor for 1 week, and they completed symptom questionnaires at the end of it. And there's a very poor correlation between perceived atrial fibrillation symptoms and the actual burden they have. If there were a correlation, you would expect to see a nice line here, but they're all over the place. Patients have no idea how much AFib they have, when they're in AFib, or how long the episodes last. So we knew that long symptomatic episodes of AFib were known to cause stroke, and the ASSERT trial asked, do brief episodes, minimum 6 minutes, that are asymptomatic, detected by pacemakers, have increased stroke risk? So they looked at these atrial high rate episodes. This is just an example one from a pacemaker. This is the rhythm strip of a pacemaker in the atrium. So you can see that there are a lot of beats detected here by the device. So this is a heart rate in the atrium of over 300. So that's an atrial high rate episode. So the study was looking for events of these lasting more than 6 minutes. And the study included about 2,580 patients with hypertension, but no AF diagnosis. These atrial high rates were detected in about 35% of patients over a 2.5-year span. And the patients who had these brief episodes had double the stroke rate as those who had none. The lesson there is that oftentimes short asymptomatic episodes of atrial fibrillation are still dangerous. The MOST trial, this is another trial examining pacemaker mode settings, had a subset of 312 patients, median age of 74 years, and 60% of them had a pre-existing diagnosis of supraventricular arrhythmia. 50% of them had at least one atrial high rate lasting more than 5 minutes, and the presence of any atrial high rate episode independently predicted a total mortality with a hazard ratio of 2.5, death or non-fatal stroke with a hazard ratio of 2.8, and progression to a clinical AFib, symptomatic AFib that would be detected in a clinic with a hazard ratio of almost 6. So brief asymptomatic episodes of atrial fibrillation are still dangerous. This is data from the Olmsted County group, I think maybe related to Mayo, but they reviewed records of adults with ECG-confirmed diagnosis of atrial fibrillation from 1980 to 2000. So this included 4,618 residents of Olmsted County. They're older, age 75 years on average. 75% of them had symptoms at the time of atrial fibrillation diagnosis. Now, the other 25% were 3 times more likely to have sustained an ischemic stroke prior to AFib diagnosis than the asymptomatic patients, even after adjusting for age, sex, and other risk factors. That same group looked at 1,000 cases with incident of AFib, and at presentation, 193 had palpitations on first diagnosis, 122 had atypical symptoms, shortness of breath, fatigue, and 161 were absolutely asymptomatic. And they found a significant discrepancy in CHADS 2 VASC scores between these symptom groups. The asymptomatic patients were generally older, and they had a higher CHADS VASC score. than the patients who had palpitations who were younger and had a lower risk score. So of 161 of the 476 patients that had asymptomatic atrial fibrillation presentation, they had a hazard ratio of 3.12 for cardiovascular mortality and 3 for all-cause mortality. And that's in comparison to the patients who had typical symptoms after adjusting for age and Chad's FAST score. So to summarize this portion, atrial fibrillation has serious healthcare consequences. It's quite common, more frequently in the elderly, and it is often asymptomatic, also more frequently in the elderly. Brief and asymptomatic episodes of atrial fibrillation carry risk of stroke. And we know that stroke due to atrial fibrillation can be prevented with anticoagulation. So the question is, shouldn't we be screening for this? You have a silent disease that is dangerous, carries risk, and can be prevented. So the European Society for Cardiology says yes. Patients who are over 65 years of age, we should check the pulse when you have an opportunity. And if it's irregular, perform an EKG. U.S. Preventive Task Force says, well, the data is inconclusive as to whether or not we should even check an EKG routinely. So, and why is that? Well, we'll talk about that here. The one population in which we definitely want to screen for AFib are the high-risk patients, the ones who we're looking to do secondary prevention, patients who have had cryptogenic stroke. So we'll talk about that population here for a little bit. So in 2014, the EMBRACE study came out, and this was comparing 24-hour Holter monitoring versus 30-day event monitoring after stroke. The standard of care at the time was to, a patient came in with a stroke, you do your evaluation, echo, monitor them on telemetry while they're admitted, discharge them with a Holter monitor, and then in follow-up, if you see them, if they have an irregular rhythm or if you have any concern, you would check an EKG, but no further monitoring after that typically. So they compared 48-hour Holter monitor, the standard of care, with using a 30-day event monitor. This study included 572 patients, 55 years and older, with a recent cryptogenic stroke or TIA. And the group wearing the 30-day event monitor detected about 45 individuals, 16%, with atrial fibrillation, whereas those wearing 24, 48 hours only detected 3%. So you miss quite a few AFib patients if you monitor for just 24 to 48 hours because atrial fibrillation is very paroxysmal. So next to come along was the Crystal AF study. And this asked, would an insertable cardiac monitor, which has a monitoring period of up to 3 years, have a higher rate of AFib detection after cryptogenic stroke than standard of care? Which again, standard of care was 24 hours of Holter, maybe 48 hours of Holter, and then EKGs and follow-up Holters at the discretion of the site investigator. It was a randomized controlled trial of 441 patients. The population was fairly young, actually, greater than 40 years of age, and had no atrial fibrillation on prior monitoring. They went under extensive evaluation in the study. They had thrombophilia panels, they had TEEs, they had advanced imaging of the head and neck. And the endpoint was the time to first detection of an AFib episode lasting more than 30 seconds. Clearly, if you monitor people for a longer period of time, you're going to detect more stroke, and that is what played out here. In the implantable cardiac monitor group, that's a year, they detected 29 individuals with atrial fibrillation, whereas in the standard of care, only 4. What I think is interesting is that in the implantable cardiac monitor group, they caught 23 patients that were asymptomatic. And in the standard of care group, only 2 asymptomatic patients. But that comprised half the patients they caught. Oral anticoagulation use in the in the implantable cardiac monitor group was double that than the standard of care group. And the patients in the implantable cardiac monitor group had fewer strokes, but unfortunately they weren't really powered for this endpoint, because that's what I'd really like to know is how many strokes do these implantable monitors prevent. So the guidelines have sort of reflected this and state that in patients with cryptogenic stroke who've undergone routine monitoring, it's reasonable to optimize detection of silent atrial fibrillation by planning a cardiac monitor. So the next question is, will implantable cardiac monitors identify high incidence of previously undiagnosed atrial fibrillation in high-risk patients? These are patients who have not had a stroke, and this is the question asked by the REVEAL AF study. In this study, 385 patients received an implantable cardiac monitor. They were observed for almost 2 years, and at 18 months, episodes of atrial fibrillation 6 minutes or more were detected in about 30%. The average time to detection was 123 days. So if you plant even an event monitor, you're going to miss quite a few cases of atrial fibrillation. Oral anticoagulants were prescribed in 56.3% of those patients. And the key points to make here is this is an observational study, not a trial. And they didn't look at the hard outcome data. They didn't really look at the number of strokes that occurred. So to summarize this point, there are difficulties in screening for atrial fibrillation. It's paroxysmal, so the relatively inexpensive ways of monitoring for atrial fibrillation, 30-day monitors, EKG, spot EKGs during clinic visits, misses the majority of atrial fibrillation. And long-duration monitoring, typically with implantable cardiac monitors, requires significant resources. They're expensive, they're invasive. So consumer companies creating monitors have seen this gap and have just jumped into the breach and offer a potentially good way of monitoring for cardiac arrhythmias with these wearable devices that can detect your heart rate all the time. They're inexpensive, and when one breaks, you can buy a new one and wear them for the rest of your life. These are a big deal. They expect to have 302 million shipments by the year 2023. And the revenue is huge as well. By 2023, we're looking at $17 billion in revenue for these devices. There are several players. Apple is the largest, but Fitbit, Garmin, others are involved as well. And the early devices began with something called photoplethysmography, which is essentially an optic technology. It makes use of the adjacent light source and camera by detecting blood volume changes in the microvasculature. So you have a sensor right next to a light source. Green works best because it's absorbed best by the blood pool. So as blood pulses through, you get a variation in absorption in the microvascular bed, indicating your pulse. These things are relatively expensive. So the first iteration of consumer heart rate monitors were phones that have a camera adjacent to a light. Now these are active heart rate measurements. On a whim, if you felt a palpitation perhaps, you could check your heart rate measurement by putting your finger over the light in the camera, and it would use photoplethysmography to measure your heart rate at that instant. They actually began to develop ways of quantifying arrhythmia too, in irregular rhythms. And these would be algorithms and apps to detect this. There's actually one device that uses an accelerometer. You hold it against your chest and it would detect your heart rate and variability in your heart rate rhythm. And those pretty much told you whether you had a normal rhythm or atrial fibrillation. And the next step forward was passive heart rate sampling. These devices would take your heart rate every few seconds to every few minutes. They would tell you whether your heart rate was low or high. The main utility of these, and these were developed primarily for exercise and fitness measurements. You could monitor your heart rate zones during exercise or see if you actually performed a certain level of activity during the course of a day. These aren't quite medical grade, though, in many cases. Here we see a comparison of the accuracy of various monitors. This is a wearable electrode-based monitor compared to the gold standard of a 12-lead EKG. So they got various individuals to wear a 12-lead EKG and these heart rate detection devices. And the wearable strap monitor actually has a pretty good correlation with the 12-lead EKG. But these various worn photoplethysmography devices don't have great correlation with the 12-lead EKG, which is probably fine for exercise, but for a medical device from diagnosing atrial fibrillation, if they don't have great reliability for heart rate, then there are obviously problems there. So I just want to go over some cases as we talk about this. 31-year-old patient who was 34 weeks pregnant was referred to me for tachycardia. She complained of intermittent shortness of breath and high heart rates, but she did not have any palpitations. This data was all coming from her Apple Watch, which showed that her heart rate was usually 120 to 130 beats, she reported, as she was noticing it. So one particular time when she was having shortness of breath, she noticed that her heart watch recorded an extremely high heart rate of 204 beats per minute. So you can see, looking at this is the report from her Apple Watch 3. Her heart rate range is typically between, I believe it's 60 to 100 beats per minute, maybe a little bit faster, and she has a few episodes that go up to about 160, 120s and 30s, which are actually probably normal for someone who's pregnant and moving around during the daytime. I could expect her heart rate to go up to 160 or if she becomes anxious. So, but not sure though, you can't say exactly what happened when she was wearing that MCOT, when she had that high rate episode. So we ordered an MCOT. That was denied by insurance. I would like to have known her heart rate variability over the course of the day, but I had to settle for a 30-day event monitor, which would detect any episodes of really rapid heart rates. And it showed that she had sinus rhythm and PVCs. Her max recorded heart rate was 160 beats per minute, and this is the strip from that episode. It's sinus rhythm, and she had a single PVC. So again, I can't go back and tell you actually what happened when she had a heart rate of 204. Could it have been an episode of SVT? Yes, but she didn't feel any differently than she did when she was having her other episodes. I think the thing that actually triggered the visit to me was the episode of a heart rate of 204, because that's kind of scary, heart rate of over 200. But it turns out I think it was a false alarm. So the next step forward in screening for atrial fibrillation is detection of passive irregular heart rhythms with these wearable devices. So these devices have to have some sort of algorithm to detect irregularity, and you're getting a lot more data because you're getting samples over several times over the course of the day. So I'm not going to go through all of this here, but this trial was a validation of a deep neural network, essentially machine learning, artificial intelligence to identify atrial fibrillation. They fed thousands and thousands of EKGs to this computer system and correlated them with actual atrial fibrillation, so the machine would learn to recognize what's AFib and what's not. And they wanted to validate this in two cohorts of patients. This first cohort here was a cardioversion cohort. They have a great ROC curve here. The area under this is fantastic, indicating it's got a great sensitivity and specificity. But in the cardioversion cohort, these patients had presented for a cardioversion, 51 of them. Almost all of them had AFib, and they were lying still in a bed about to undergo cardioversion. Study personnel put the device on them and stared at them and told them to be still while they took the measurements. They also didn't use real-world settings. They put the device in a workout mode, which takes samples every 5 seconds, which would drain your battery too quickly. Now, you put them on people walking around in the world, and it's terrible. It's hardly useful at all. So this is a photoplethysmography, easy for me to say, that device that takes instantaneous measurements and in real-world settings does not have good accuracy. So one of the better studies, and that for AFib period as far as numbers, is the Apple Heart Study. And they try to adjust this issue by taking what are called tachograms. So a tachogram is a sampling of several beats, and they look at the RR intervals to see if they're irregular or not. So one tachogram would correlate to the spot EKG done by the previous iterations of devices. But a single tachogram did not get you a notification. If you had a normal tachogram, normal RR intervals, the device kept monitoring periodically. But if you had an abnormal tachogram, a brief sampling with irregular RR intervals consistent with AFib, it would increase the sampling rate. And if the irregularity wasn't confirmed, then it would go back to sampling at normal intervals. But if you had 5 out of 6 irregular tachograms within a short period, the watch gave you a notification. So the people in this trial were US residents, 22 years of age and older. They had an iPhone 5 and an Apple Watch Series 1 through 3. They had no history of atrial fibrillation or flutter, and they weren't on anticoagulation. So if they received a notification while wearing the watch, they received a message from their app, and after talking to a telehealth doctor, they may have been sent an ECG patch. This would be a 5-day Holter patch to detect whether they had atrial fibrillation episodes 5-6 days after they received a notification when they received these patches over a duration of 5 days. So what they were looking for was AFib of a duration of 30 seconds on an ECG patch that was worn several days after they had their notification. A secondary endpoint was while they were wearing the patch, did they have atrial fibrillation on the patch at the time they received the notification? So they did a pretty good job. They recruited 420,000 individuals. Now, a lot of them were young, as you would expect in a population wearing a wearable device, but they did get 24,000 patients over the age of 65. They were hoping to get 25,000 and 500 patients, but they didn't quite meet this endpoint. And what they report here is the positive predictive value. And for the overall cohort, they report a positive predictive value of 0.71 for the tachogram, an individual recording, and 0.86 for the series of tachograms that gives you a notification. There's a lot of challenges to this, though. Obviously, it's not a trial in that it's not controlled. And there's a lot of dropout. The young patients, only 21% of them who were told to, who had a notification actually wore the patch. That's 61% less than older patients. And as we know, younger patients are less likely to have AFib. So that means that those notifications were more likely to be false positives. So if you go through the data, and actually they didn't report this, but if you calculate out the specificity, it's pretty good, 95%, but the sensitivity is fairly bad, it's 47%. So if you apply this to the population of young patients, the positive predictive value is no more than 34%. So that means that of people who get a positive notification, only about 34% of them at best will actually have the disease. And some people calculate this as low as 5% if you're talking about very young patients, because young patients have a prevalence of less than 1%. So likely more than 90% of alerts will be false alarms in younger patients. And also interestingly, 57% of the patients who received a notification went to their doctor. So that's a lot of patients receiving notifications going to some healthcare professional to get feedback. So another case, a 63-year-old female. She has symptomatic paroxysmal atrial fibrillation, and she went pulmonary vein isolation for atrial fibrillation ablation. So she returned 2 months later for follow-up, and her smartwatch recorded episodes of irregular RR intervals and rapid rates. However, she didn't feel a thing. She felt fine, and she'd been previously very symptomatic with episodes. So she was wearing an Apple Watch 3, and it notified her that she had atrial fibrillation, several irregular episodes. So I put an MCOT on her, and she wore the MCOT, but it did not detect any atrial fibrillation by the watch or the MCOT. So whatever she was happening previously apparently wasn't happening now, but she did have new onset of rapid palpitations. And her smartwatch with these detected a high rate, but no atrial fibrillation. And this is what her watch recorded. You can see several heart rates here in the normal range between, I think, 60 and 100. But there's a distinct band right here centered around 150. And these are just a list of episodes that she had, of episodes about 150 beats a minute or so. And this is what her MCOT detected. It's typical atrial flutter. Now, I didn't ablate typical atrial flutter. I wouldn't call this a failure of the ablation. It was a different arrhythmia that she didn't have earlier. So what did the watch do for us here? Well, it led me to place an MCOT, but she didn't actually have the rhythm of interest while she was wearing the MCOT. And it did detect an arrhythmia that was highly symptomatic, and we would have diagnosed it anyway because she would have come in and we would have put a monitor on at that point that would have detected this arrhythmia. So moving forward, the next version of, next iteration would be these ad hoc ECGs. There's several of them. The Apple Watch 4, you can put your finger on the bezel of the Apple Watch and essentially detects as a lead 1 EKG from your right hand to your left. An earlier one is the AliveCore, which can be seen here. Essentially, you put your 2 fingers on this, it pairs with an app, and it also gives you a lead 1 EKG from the right arm to the left arm. And these have also, the idea of these is to be able to determine whether the patient is in normal sinus rhythm or has atrial fibrillation. And I will say, these have pretty good tracing quality. It's both me. My heart rate's probably faster right now. But here, on the KardioMobile, you can clearly see P waves and QRS complexes, T waves, and this is an Apple Watch 4 tracing. So there's not a lot of data, however, for the Apple Watch 4. These devices are both cleared by the FDA, but the information that Apple gave the FDA is not publicly available. There is data, however, for the AliveCore. This was a study in which the AliveCore was brought to both a cardiology ward and a geriatric ward and given to the patients there. I believe the prevalence in these populations on average was about 36%, and 11% of them had atrial fibrillation at the time of the study. The sensitivity was pretty good, around 80%, and the specificity around 95%. Now, this is another device called the My Diagnostic, which I've not seen available here locally, but it's just another similar device that detects your rhythm and can actually give you an ad hoc EKG. So in this study, 1,000 individuals 65 years or older were screened, and ECGs were performed with AliveCore during pharmacy visits in the UK. The mean age was about 80 years, and on these ad hoc visits to a pharmacy, when they said, hey, just let's see what your heart rhythm is, they found that the device had a 98% sensitivity and 91.4% specificity. Now, however, newly diagnosed AFib was detected in only 1.5% of the population. So it's not that the device detects or diagnoses atrial fibrillation in patients with a specificity of 91.4% and sensitivity of 98.5%. When the device registered an EKG, and that EKG is also looked over by a cardiologist, 98% of the time and 91% of the time, the device algorithm gets it right. You would expect, if we detected every case of atrial fibrillation, we would detect a lot more cases than 1.5%. So these ad hoc EKGs are missing a lot of atrial fibrillation, as you would expect. So the best modality would be a blended sensor, something that monitors your heart rate all the time, and then can give you an EKG, which will have a much better diagnostic value. So the AliveCore and the Apple Watch 4 both have FDA clearance. Now, FDA clearance is not FDA approval. FDA approval is something for medical devices that actually have some risk. So clearance is something that's maybe for something between a tongue depressor and a defibrillator. The notification systems based on photoplethysmography are relatively poor. They have poor sensitivity, maybe 40, 50% in some populations. But in both devices, the EKG is very accurate. And as I mentioned earlier, the data behind the ECG function of the Apple Watch is just not readily available. It's not peer-reviewed. So another case. This is a 43-year-old man who's diabetic, obese, probably has sleep apnea based upon the brief history we're getting from him and his snoring. He was sitting in his truck at work one day and had an odd sensation in his throat and immediately received a notification from his Apple Watch of suspected atrial fibrillation. And then this is the sort of notification it gives you. Your heart has shown signs of an irregular rhythm suggestive of atrial fibrillation. And this is the sort of data that generates that. So heart rate variability was very high, 252 milliseconds. The lady with atrial flutter, whose watch did not detect heart rate variability, hers was 11 milliseconds of variability. So, and in flutter, her rate was very consistent. Here, high variability in the rate, during episodes. So, and this is a graph of that. So his heart rate is actually fairly stable, then all of a sudden jumps up. So it prompted him to take an EKG with his watch. And because the algorithm is not really tuned to it, it could not make a comment because the rate was over 120 beats a minute. So he came to the hospital. He got put on a diltiazem drip, and his heart rate slowed down. We can see that this is atrial fibrillation, but the algorithm can't comment on it until his heart rate's less than 120. And then it correctly defined this rhythm as atrial fibrillation. So a second case. This is a 30-year-old healthy patient who receives an irregular rhythm notification from his watch. And this is what it shows. ECG shows signs of atrial fibrillation. But looking at this, there's no atrial fibrillation. There's P waves throughout here. And he has PVCs and a pause, P wave, and then several PACs. And unfortunately, in my experience, this is often the case, that you have what the device thinks is atrial fibrillation, but it's a false positive. So also another case, a 61-year-old woman who had a history of typical atrial flutter. She underwent TE and cardioversion twice in 2018 and returned to me after a second recurrence, or she actually was referred to me after a second recurrence. She underwent an atrial flutter ablation, and she showed up in follow-up 2 months later, no evidence of recurrence, and because the success rate of atrial flutter ablation is about 95%, if she's doing well, you can safely take them off anticoagulation. So that's what I did, discontinue her anticoagulation. She has a smartwatch that she uses to monitor her heart rhythm. And one day she calls me up because she's starting to have palpitations. And she actually texts me and sends me this EKG. And I text her right back and say, your palpitations are due to PVCs. Not flutter, not atrial fibrillation, but in a patient with a prior history of atrial arrhythmia, atrial flutter, you have to ask yourself, if somebody calls you up and says, I'm having palpitations now, is she having recurrence of flutter? Is she now having atrial fibrillation? So the data from her, the ECG from her Apple Watch actually prevented her from having an ER visit or an urgent clinic visit to get an EKG to detect what was going on, prevented her from having additional monitoring, because I surely would have placed an MCOT on her, and possibly resumed anticoagulation because she could have been at risk for atrial fibrillation until we sorted everything out. So that exchange took place because the patient was actually texting me, sending me emails about her condition, and sending me EKG strips via text. So the question is, well, there's several questions. It's changing the patient-doctor relationship. One question is about liability. If a patient has an episode they feel weird, and they email me an EKG from their watch that shows a run of ventricular tachycardia, and it's sitting in my email box because I'm on vacation for a week, am I liable for that? The Cardiac has actually developed a clearinghouse for which urgent notifications are sent and put in the queue for official review. But certainly it's not standardized yet. And I know that some physicians are actually meeting with patients in clinic, having them sign a consent form and a waiver form agreeing to the terms. If you're going to contact me with information from your Apple Watch, this is how it's going to be. Here are the restrictions and limitations. Cybersecurity is an issue. PDFs are sent through text or email. The Cardiac also has this password, dual protection password. So if you generate a PDF of your heart rhythm, and you can email it to your doctor, but you also have to generate a secondary password, which you can text them, so it has a bit more authentication. I guess a patient could send this to you through MindChart as well, which would be a better way of doing it. Reimbursement, there's no billable code for transmitted consumer EKGs at this point. And of course, there's the questions of patient care. Although patient engagement, people controlling their information has been shown to improve outcomes, there's still concerns about how this is going to affect patients, how we're going to be able to give care effectively. These devices have a low positive predictive value. They're going to generate a lot of false positives, leading to unwarranted anxiety among patients who get and probably lead to an increased burden of unnecessary confirmatory tests. And the low sensitivity of these devices can lead to a false sense of security as real events are missed. So this was a review on one of these apps. After having a heart attack a couple years ago, I was looking for a device to check my EKG without going to the doctor for a good price and no monthly charge. This is the product for me. And these things don't even detect, ST changes. This is scary to me. These patients think, I'm chest pain. Oh, I'm okay. So, yeah, exactly, a built-in defibrillator. So, just some conclusions. General population-based screening for atrial fibrillation is a worthy goal, but it's difficult. Due to the paroxysmal nature of atrial fibrillation, you've got to monitor for long terms to catch episodes. And the modalities we have to do this right now are expensive. The best thing we have are the implantable loop monitors, but that's an invasive procedure. What if you plant one at somebody at age 65? Do you just keep implanting loop monitors for the rest of their life? That's not a really feasible way of monitoring at this point. So we didn't talk about this a great deal, but we don't really know what duration of AF presents risk for stroke sufficient to warrant anticoagulation. I've mentioned a couple different studies. The MOST trial subset and the ASSERT, they use 6 minutes, and that's the best data we have, minimum duration of 6 minutes that actually leads to stroke. We've been using 30 seconds, but we don't really have good data that 30-second episodes of atrial fibrillation cause stroke. We suspect it and act on that, and it'll probably be difficult to get equipoise for a trial to prove it, but we just don't know at this point. And then these watches will start detecting episodes that could be just a few seconds in duration. And what we do about those, we just don't know. So commercially available monitors are an emerging technology with promise, yet they're imprecise. There are a lot of questions remain, and we just have to evolve with this changing landscape. So, thank you. All right, thanks.
The incidence of stroke change with the morphology of the atrial appendage?
That's